Welcome, everyone. I am really very excited that you're here, Michael. Not just because your name is just a great name, but anyway. Um, but this is really today. We're going to have a really, just a free form discussion and everything you're doing to mitigate lessen or really help us understand what loneliness is. But before we get into this conversation about what it is and what you're doing, please just briefly introduce yourself. So great to have you here.
Great. Yeah, thank you. Michael Oleksiw, I'm the CEO of Pielo, but first and foremost, a father, a husband, owner of a wonderful mischievous collie, and spent most of my career, and definitely am targeted right now on focusing on how people and technology could come together to build a path to a better world. That's me.
Well, this is great. So tell me how it started. I mean, obviously this just didn't happen overnight.
No. So, I kind of was brought into Pleo, where there was this concept. A think tank group came together and was thinking about the challenges people have when they're starting their medications, and a lot of brainstorming, in terms of what those problems are and what those pathways are. And, fast forward, long story short, we chose to focus on medication adherence. We basically realized that when folks were given a diagnosis and starting out on a medication, the vast majority of them, 40, 50, 60%, stopped taking their medications within 30 days. Then as we kind of dug deeper, we saw that this was a really, really complex problem that's multifaceted. And I would say over the last decade, we just continue to learn as to really how complex this problem is. And I think we'll be diving into one of the most intriguing parts of the medication journey, which is, all around the emotional barriers that target patients when they're on medications.
So can you repeat that? Did you say, is it 50% do not complete 30 days of their medication?
That is correct. Depending on the medications, but we're talking about medications that people who become patients are prescribed by their doctors for chronic diseases. So these are medications that they need to take every day because they're sick. And sometimes they're asymptomatic and, they need to take the medication to mitigate illness. And others, if they stop taking the medication, they feel sick. And I say vast majority because I think anything over 10% is vast majority when it comes to taking a medication. But those are the numbers. Over half of patients discontinue their medications by that first fill. And those numbers, kind of get worse as you kind of go further on.
So what do you think, from I guess you've been 10 years in, I mean, this is not overnight. What are you finding that, I imagine the first and foremost is huge amounts of education for the providers, the physicians, the groups, what this patient journey is. I imagine you have a real empathetic understanding with this. And can you share kind of that experience? Because that seems to be unlocking that. If you don't know your customer, how can you solve their problems?
Sure. And, I think I started out by saying that this is, this is complex. And why is it complex? We're talking about human behavior. We're talking about people. No two, persons are alike. So we always try to kind of simplify problems, break them down, and look at what we can impact. Determine our swim lane. What is it that we can impact? What are we good at? And when it comes to patient journeys, we realized there are essentially sort of two broad areas. One of which is the transaction or access to the medication. Can I afford the medication? Can I get the medication? Could I make it to the pharmacy? Could the medication make it to my home? That sort of stuff. Very physical, mechanical, transactional type barriers. Then there are the emotional barriers. I'm scared of side effects. I've never injected myself before. My neighbor says I don't need this medication and I should, take cod liver oil. There are just a variety of things that kind of come to play. And what we've seen, the AMA has actually published published studies, right, on reasons or barriers to medication non-adherence. And 5 out of the 8 barriers that they publish, the majority of the barriers are emotional in nature. So what we sort of, and I say stumbled upon, and I say that humbly because we did stumble upon this as we began speaking to patients over the years. In speaking to patients, we got to dig into what is it that's really affecting these patients. And I can say one of the things that we heard early on, or a quote that we hear from patients is, "This is interesting that you're reaching out to me. I really appreciate it because it's very rare that someone from outside of my family gives me a call to see how I'm doing, let alone when I'm starting a medication." And then as the years kind of gone on, and now we're getting, we're using some proprietary AI, and we're getting into conversational analytics. We're seeing that, that phrase, "I don't get calls from people outside of my family that care about me." We see that more and more. And we basically are, using data, technology, and just, listening to people. We're trying to understand, why are they saying this, and what does it have? What impact does it have on their medication journey? What impact does it have on their health? These are sort of the kind of existential questions that we kind of always put in front of us.
So who is your ideal customer? Is it pharmacy? Your organization's very interesting. I imagine you probably you could have. I mean, I could see some CRO potential. I can see the pharma trials in that area. I could see, of course, providers with value-based groups, payers, ACOs. I'm sure all of those can be just for our audience to help, get another, there's so many people listening that have lots of different backgrounds and perspectives. Love to hear kind of more about kind of who your ideal customers are.
Yeah. So, we're very much patient first. So, anywhere that there's a patient starting out on a medication journey, and I say starting out, they could be experienced, with gaps in therapy, but anytime that they're initiating, they may be on several meds, but they're initiating, a new med, anywhere that you find that patient initiating therapy. So the bulk of the work that we do really stems from e-prescribing. So patients are prescribed a medication. Within hours of that prescription being written, we reach out to them. And the second is pharmacy. So patients fill at a pharmacy. Within a day, we're reaching out to them. And what we're looking to do there in the first case is mitigate, primary abandonment, right? Folks that just don't pick up their medication for any one of those emotional reasons. And then in the second case, in pharmacy, we're looking to mitigate that first fill drop off, or the famous leaky bucket. But this, again, could extend to payer groups. The same issues exist for clinical trials in terms of initiating and engaging. So anywhere that you sort of have that engagement problem with the medication.
Will you actually deliver the medication? Do you how does your company work, like with the jobs and tasks to be done?
Yeah. So again, we focus strictly on those emotional behavioral barriers. Mm-hmm. So we partner and work with organizations that handle the mechanics, that deliver the medication, prescribe the medication, get it into the patient's hand. Our job, if I really want to oversimplify it, our goal in life is to unoverwhelm the patient. From the time they've received the diagnosis, they're told what they need to do for the rest of their life. They're given, they're given lots of documentation. They're given a lot of tools to work with. They're given a lot of work. They're given a lot of homework. Our goal is to intervene in this, perfect trough of disillusionment where they've got all this stimulus coming at them, and we connect with them, as a person, reminding them they're a person, reminding them it's okay to be, to take a medication, drop the stigma, address, loneliness, which is augmented, when patients begin their medication journeys. It's a high correlation. So we really, our outreach, our delivery complements, again, all of those mechanical, transactional, or kind of physical partners. But our outreach is typically via phone. very shortly after the patient has been either prescribed or has picked up a medication, and then follows through with a variety of digital tactics to kind of support the initial rapport that we build.
And what is something that's been so counterintuitive about this journey, helping, with medication adherence?
Yeah, I think again the prevalence of the emotional barriers is counterintuitive because again you're sick, you're been prescribed a medication, proven medications, right? For obviously the vast majority of cases, and you just stop taking them, right? So the whole issue of medication adherence is just fascinating because that drop off is so big and so counterintuitive.
Mm-hmm.
Because it would appear simple if you have the medication in hand. It's paid for. You've been able to afford it at this point. You've got it in hand, and it's sitting in your medicine cabinet, and you're not taking it. In my mind, that's one of the most counterintuitive components that we see in the journey.
And so I imagine, most of us, after a certain point in time, we're patients, we're members, we've had experience with the healthcare system. And I know the little bit that I have, there's so little follow-up and care. And I will get text messages from CVS, but it's like a flu vaccine, I think of recent or whatever. And whether it be from my provider, there's really very little of what you're doing. And so there's such a gap in that understanding. So it seems to be you are the helper, the eyes and ears of that member, that patient. And you're getting a lot of insight. So it seems like there's so many things that providers can gather from your experience.
Yeah, so we say that these diagnoses and chronic disease diagnosis is sort of a tipping point, right? A tipping point for these emotional barriers, for things like loneliness. And you mentioned the stimulus you get, right? That you'll get the texting, you'll get the reminders, you'll get a late to refill reminder, and a lot of these behaviorally, we call them nudges because that kind of veils them and has them sound a little nicer. But at the end of the day, a lot of these, we're poking a patient that is overwhelmed. We're reminding them, and in reminding them, often what we're doing is we're just suggesting that they're forgetful, and we're adding to the emotional burden of the medication. So we take a little bit of a different approach. Again, we look to unoverwhelm, we look to build knowledge, confidence, and skills, and then have the patients, choose their method of being reminded if that's what works for them, nudged if that's what works, using an app if that's what works for them. What we want to avoid is basically, throwing all these. We want to avoid basically adding friction to the journey. And our belief is if we get the patient to buy into their journey and they have that confidence, they're going to pick the tools that are right for them. But it doesn't need to be all the tools, and we don't decide the tools, right? The patient will naturally choose what's best for them. And this is where our technology and our comes into play in terms of really better understanding patients' emotions, journeys, and triggers, and how to speak to patients so that we can get them what they really, really need.
Well, tell me a little bit about this loneliness. Is there any involvement to help mitigate that? You're seeing that, but tell me what's going on with that.
Yeah, so this is probably the most fascinating and interesting part of my life with Pielo in the last year. So we've been working with patients and talking to patients, as we said, for a very long time. And along the way, we've picked up on different behavioral change models that apply to what we do, and we've backed into them. It's not like we said, oh, there's this great behavior change model, let's apply it. Quite truthfully, we were reaching out to patients and we realized, well, there's a label for what we're doing. And if we tweak it a little bit, we kind of fit into this model. So we've evolved our models. And I mentioned that, we started to hear more and more that patients were saying, I don't get calls like this from outside of, people outside of my family. And we dug into that, through the AI, got to understand that, wait a minute, these people are telling us they're lonely. So what we did this past year, we commissioned a study, which is pretty significant for a company like ours. And we also began to work with Dr. Jeremy Nobel, author of Project Unlonely, to really understand the role that loneliness has on health behaviors. And our study, which is available for download, is eye-opening. Just across the board in terms of the impact that loneliness has on health. Loneliness in terms of being equated to smoking a pack of cigarettes a day, with physical manifestations, increasing inflammation markers, immune function, just by being lonely, right? Just straight up loneliness. So we've really dug in deep and realized that we're actually putting a dent in loneliness, which has a direct impact on these med journeys.
And where is that again? Where can the audience find that study? Where would they find that?
Yeah, we've got that on our website, and we could definitely post a link here.
Okay, awesome. So that would be great. And I'll also post that on the follow-up when I put this out. So I'll definitely do that. I think that's fascinating. And tell us, we kind of all understand what loneliness is, but if you operationalize it, what is it? Is it just the state of thinking or feeling like you're lonely? Or how many touches you have with social? Is there some sort of scientific metrics that we try to equivocate what that really is? You can be, have I imagine there is some, metrics, how we define a scale of loneliness, or is there not?
Yeah, there are, and in kind of working with Dr. Nobel, we're really getting to understand it, but it really comes down to feelings of emptiness, lack of companionship, feeling left out, feeling isolated, lack of connection. And there are definitely measures which are things that we use in our practice. We don't very well routed in academia. But I can tell you, if I look at just articles that I've seen in the last week, in terms again of the impact of loneliness. So we've seen a lot on blue zones and the impact of community on longevity. But there's an article I was reading in BBC's Science Focus that was about social fitness in terms of being predictors of a happy life, and how again, folks that were part of community, part of society, and more connected, basically just lived longer and are more healthy. And I'm seeing more and more of this, pop up, and definitely a product of the pandemic that kind of threw us into different levels of isolation and had us really kind of be more introspective about what loneliness is.
Mm-hmm. Do you have any sort of peer support program? Because it seems like the little from my experience, the best way to not be lonely is stop thinking about yourself and start thinking about others. There's a lot of powerful, a little bit that I've done from my research when I start, and also with the teenager, that, the moment my daughter started getting involved with volunteering through different organizations, oh my gosh, it just lifted, so it seems like to me that's a universal point. Is there any evidence on that, and maybe with the blue zones, is there more of a communal element where you're actually doing more for the group and less for yourself? I don't know. Do you have anything to share with that? I know that was a long question. Forgive me.
Yeah, yeah. And usually I'm the one. Usually I have long responses, but no. There's definitely a lot out there that's kind of again gone into our work. I can speak to sort of how we approach it and what we see specifically, with patients. So our model is a kind of a peer-to-patient model where the folks that we have reaching out to patients are people just like the patients. How they are not, they're lay people, right? So we kind of break white coat syndrome, allow HCPs to work to top of license, and we focus on that human connection. But when you receive a call from us, you're receiving a call from someone just like you that looks and sounds like you, not necessarily dealing with the same, the same medication journey, but that connection basically, again, having someone connect with you so that it's okay. The stigma of being sick is dropped. Someone, again, from outside your family reaching out to see, how you're doing, not telling you what to do or why you should do it, but just that simple connection is sort of what opens the door.
So it almost sounds like the power of the 12 steps. It's like the last step in the AA is that you go help. You go become a volunteer, and they have a powerful way of, they're not telling you, so anyway, I don't want to sidetrack, but it seems like there's a lot of 12-step principles across the board with that peer support sort of element, the fact that it's someone that's got that lived experience, however you want to call it. But so really what you're sharing is that the DNA, the special sauce of your, getting that KPI, getting that ROI, is that you have those people in that journey that can really empathetically, relate to your end customer.
Yeah, and I think that's the key word, relate. So getting a call, connecting with someone like you, right? That's, again, doesn't have that hierarchy. You have compassionate, empathetic pharmacists and physicians, but they still wear a white coat and they still have a certain hierarchy relative to the patient. So I think that relatable component is a key part to the connection. But when folks kind of look at the loneliness survey that we'll post, we ask patients at the end. We basically asked, if peer support, if they feel peer support would help their loneliness, and the answer is 89%. 89% of patients felt that it would help them. And it is, we found over the years, it's always difficult to understand what make patients tick or not. This is one of those rare instances where it's overwhelmingly in one direction in terms of, peer support. Peer support would absolutely help me.
So it sounds like you have a really effective model for scaling. Most of everything is either telephonically or remote. And I imagine, are you global? You're in the States. Tell me a little bit about your reach.
Yeah, so right now we're working 100% in the US. We're very, very kind of focused and targeted. We have a lot of demand to bring the model to other theaters globally with the pharmaceutical manufacturers with whom we work. I think for the foreseeable future, we'll be strictly focused in the US because there's still a lot of work to be done, and we're putting a dent in our patient populations. But there's still a lot of loneliness out there, and quite frankly, it's increasing.
Would you help our audience understand a little bit, like the trends, like your population? If there's, maybe if I don't know everything about your company, whether it be some substance abuse disorder, opiates, or whether it be behavioral health, mental health, whether it be diet. I mean, obviously we have pockets like cardiovascular disease. Can you share a little bit of breaking down those categories and how your peer supports are being utilized for that?
Sure. So we work across the full gambit of chronic disease meds, extensive work in diabetes, cardiovascular. We are doing a ton of work on GLP-1s, diabetes, and obesity. You would think with some of the obesity meds that you would not have an adherence problem, right? Because the numbers are great, they work. So we're seeing a great impact there. But we've done a lot of work also in mental health with antipsychotics and major depressive disorder. We've seen the greatest impact in mental health. That's probably where we see the greatest impact. But For the most part, our results across all disease states are pretty tightly, clustered. But we've touched most of the main disease states, and we're doing, we did some work in HIV, men's health, women's health, so on and so forth.
And there's just so much that's gathered by those conversations. It's just, I formerly had, I was a social worker in skilled nursing facilities. I also had a care management organization, and I was, fortunate to get to go periodically to members' homes. And you find out really quick when you're trying to engage with someone on their cell phone, they're dual eligible, however, and those barriers to healthcare. I think, thank goodness, we have the understanding of SDOH, all these barriers to health, but every day you're finding that and doing that. And so how would these organizations kind of get involved with you? I know it's probably a B2B, but I imagine how are you finding your right fit clients and customers?
Yeah. So the first, there's always a level of education, right? In terms of determining where organizations are relative to understanding, medication journeys and where the goals are. Our focus is really on those organizations that have recognized that they sort of have, an engagement challenge, meaning, a lot of them, they believe that they have a level of engagement, but what does engagement really mean, right? It doesn't mean that, a patient opted into, let's say, receive text messages, goes through 3 text messages, isn't done with no behavior change, right? So we're basically looking to those organizations that have a recognition of the emotional components. And I would say, one of our main targets right now is to really work with organizations that are highly focused on, let's say, the cost components, things like prior authorization, benefits verification, or clinical services, because we fit perfectly in the middle of all that, because we are able to connect with patients at scale at low cost, because we're non-healthcare professionals in our model, right? Regular people calling folks. And we tend to be that magnifier because we are very strong at engaging, bringing patients into the mix, and then connecting them with, again, the tools that'll work for them. So we kind of fit, we're not a silver bullet. We're more of a force multiplier and a catalyst for a lot of the other kind of tactics that exist. We tend to make them better.
Yeah, I hear that. You have a real agnostic approach at really solving. It seems like that has been your growth strategy, I imagine, because this is a really tough problem, and how do you tackle it? And so it seems like you have a nice niche across the different disease states, conditions, i.e., with helping those individuals. And is it right now we're in a different landscape as well? I mean, I don't want to say administratively, but has that changed in any way for you as an organization and how you create partnerships or look for the right fit organizations?
Yeah, it is not. We're very disciplined and focused, and by definition, our programs are white label. So from a partnership perspective, we'll assume the identity of any existing program. So just generally philosophically, we're very agnostic in sort of in the mix. But in terms of, let's say, policy and sort of, kind of shifting thoughts, we haven't been impacted by anything that has landed yet. And our belief is we'll wait till something actually lands, if it lands. But quite frankly, as long as we stay focused on the patient and we're bettering patients' lives, we believe that there will be, good that'll come out of it. And our goal is to just adapt, keeping that patient centricity.
So the white label, how is it, a little bit about business model. How do you make money? How do you work with partners?
Yeah. So one of our core models essentially is working with, again, e-prescribers and pharmacy, who essentially will provide access to patients, right? So we'll basically reach out in partnership with pharmacy, in partnership with the prescriber, um, and those programs will typically be sponsored by the manufacturer of the medication. So in terms of the program being white label, um, Pleo is not a name that's often heard. Where Pleo is the name on the contract. Our white label moniker is typically Good Start. Good Start for patients starting new therapy programs out of pharmacy. So the program will take the name of the pharmacy, and it'll be the Pharmacy Good Start program. If we're looking at one of those e-prescriber programs, we call those our day one programs, and that day one moniker will be added to whatever the identity may be, coming out of the e-prescriber. And then there are other instances where we are the de facto patient support program for the manufacturer. So if you go to the manufacturer's website for a specific medication and you sign up for support, it's all us on the back end, but totally assuming the identity of the manufacturer, or the brand, I should say.
So where does this come with? I know there's been a lot of talk with like device, RPM, RTM. Is there any element of RPM on this with the engagement? There's a lot of different ways that people and organizations. Is there any involvement in that with coding to help providers with revenue share?
So we haven't touched at all on that yet. We have it a little distant, on our radar through some partnerships, just by virtue of our connectivity and our data, and with some of the devices. We've looked at, we have some great discussions and some great partners, and like smart medicine cabinets and things like that, which have some promise in perhaps a little bit of a longer term. But that's not, we haven't really moved out there yet. We're really strictly focused on new to therapy adherence, but
And
there are definitely extensions.
so most of the I guess the big bit of your partnerships are with the organizations that have a newer therapy, and it's very important that they get those to the customer.
Correct. So we do a lot of launch medications. We do mature brands. We also work with program drugs, kind of post LOE. So we run the full life cycle, but definitely launch brands, particularly like novel products, tend to be our starting point. But our tenure with brands, with individual brands, is quite long. We run our programs for 5, in some cases 9 years straight. So this isn't the type of tactic that just kind of gets dropped after a year. Part of it's the way we work. Another part is this long-term relationship we develop with the patient that's recognized. But then third-party results. This is a proven program. It's been running for a long time across multiple manufacturers, reviewed by multiple third parties, audited by manufacturers. So we have a lot of proof points.
And so it seems like with your platform, you're really highlighting the robust, 9 years that you're running, obviously creating value. What are you doing internally to create what I would say those Sherpas, those peer support? I mean, that's really your next engine, not only the technology, the relation with these manufacturers, these drugs. How do you kind of make sure you're ensuring that quality with your peer support, that they're really satisfying that?
Yeah, no, that's a great question. So one of the things we did is we built our technology platform first before we sold anything. So we're tech-enabled services. So the folks that we have reaching out to patients are informed by technology, monitored by technology, trained by technology. So we have a platform that we call Lift, and then we have an AI component called Ollie, that's conversational analytics, and it basically does everything from bringing in the data, from patient data, from pharmacy, e-prescriber, matches, the good starter, the person making the call with the patient, trains. We have a Good Start U, a full online training facility for the good starters. They go through background checks. We have independent QA. There's full compliance monitoring on these folks. But more importantly, the good starters are part of a community that learn and share experiences amongst themselves. So we actually practice what we preach internally. So our technology is really the enabler that allows us to be efficient, but most importantly, compliant in a very highly regulated compliance environment. But I think the most exciting piece right now is really the Ollie piece, which is our conversational AI, which uses AI not to replace the human, but inform the human to make better word choices, better decisions, and learn more about the patients. So what we would have to listen to just a few years ago is being done for us while we sleep, and we're getting those summaries. We have our giant Venn diagrams that'll show us overlapping barriers and then tell us what to do about them. So we have a really good continuous improvement loop that's driven by technology.
So how many good starters do you currently have?
So the count of good starters, it's a variable workforce gig economy model, very much like Uber. So we at any given time have hundreds that are engaged. We're probably pushing around 300 to 400 right now. But depending on the programs we're running, we're never the bottleneck when it comes to ramp up, which is one of the good things about working in pharma.
It seems like with what you described, that AI using your proprietary Lift, your platform and all that, I mean, it's not like, as I've, try to continue to learn more and more every day in healthcare, all the stakeholders, specifically when I'm talking about RPM, where there's minutes involved, or kind of like an encounter with a clinician, you're freed up because you can really execute on value, create that value, utilize AI, and the scalability is, oh my gosh. So I guess you are very venture friendly in some sense. Of course, it's not totally software, but it's the most efficient and effective way to use people, software, technologies to really truly scale.
Exactly. And, I mentioned earlier, we spoke about white coat syndrome, but I think what's more important is really allowing, the healthcare professionals, the nurses, nurse practitioners, physicians, even coaches to a certain degree, diabetes educators, allow them to work to top of license, because there is a relatively finite set of them, and they're limited in terms of the time that they can spend. By virtue of our model, we're limited. We don't have those limitations, right? And our purpose is different, right? Our purpose is to connect as humans. We don't have those kind of defined, discrete tasks that get measured in that same way.
Could you, in some sense, as you started this journey, what your hypothesis was, or what the company's hypothesis is, and how it's changed I always love to hear how companies come about and where they go. Has there been any really clear pivots? Obviously Sony, this is a weird one. I might be wrong, but I think they were a rice cooking Sony electronic. Maybe that was their first line or something, but I just find it fascinating. I'd love to hear that for you here.
Yeah. So the one that there are definitely always a lot of pivots, but if I kind of think about the early days, I think the first working premise was, people forget to take their medications. It's forgetfulness. So everything was kind of driven by reminding the patient, hey, we're calling to tell you, it was remind. And one of the things that we had early on was a texting program where we would ask the patient, hey, I can send you a reminder to take your medication by text. Would you like that? we had 10 to 15% of patients that would opt in. Over the course of time, we learned that it's more complicated than that. And we began to offer these Good Start minutes as, hey, I speak with a lot of patients like you. They tell me they can use a positive health message around the time that they take their medication. Our number shot up to 30% to now we're 50%. So we get about 50% opt-in there. And what happened over that time is we went from saying, hey, we're going to remind someone and suggest to them that they're forgetful, to we're going to recognize that they're not alone in their journey. We speak to patients like them, and that they're empowered to do something and take a step. And that changed wow. Everything. So I think as we saw that, this is pre-AI where we saw the simple numbers in terms of opt-ins. I think that was kind of the canary in the coal mine that led us to say, wait a minute, like our fantastic, we call them creative medical writers, a little bit of a paradox, but our writers basically came up with these subtle changes, thinking that there would be, the hypothesis was that it would be better for behavior change, and it was. So now we could just do that, in real time.
So it sounds like that's really behavioral science based, way more effective, that you guys really captured that. While we're here, we're kind of coming towards the end. I really appreciate your time, Michael. Is there, where are you as a company with a raise? I mean, this is your time here. I mean, would you like to share if you're raising another round, your big milestones, anything as you hear from? Yeah.
Yeah. So, we've been quite fortunate that we have some great investors that have been with us for a very long time. And have allowed us to grow in a very disciplined fashion. We're at that next point of growth now where, commercial acceleration and, one of the things you asked early on was, employer groups, health plans, et cetera, is really expanding our horizons outside of, the spaces that we're in today, because we have a working model. We have a fantastic use case. So we're really looking at that commercial acceleration, and we're looking at that, we're thinking about how to approach that. We're profitable as a company. We're growing. We have all those good things. Our numbers are exactly where we want them to be. So we're really pondering how to take that. We're looking for that quantum leap. We've been comfortable. So we're looking at that quantum leap now.
So I would imagine connecting the dots, it's probably going to, what would be nice is some partnerships with some payers, and I guess to get those amount of lives, I imagine at some level, at the right area, one area that you probably would be interested with.
Correct. Correct. If you're looking at, payers continuing to grow our network of pharmacies, independent pharmacies are struggling, community pharmacies are struggling. We provide them a great outreach to patients that goes beyond their walls, beyond the bricks and mortar, and what, that single pharmacist can do. So we're very, very strong at that. Specialty pharmacy, augmenting the work of the hubs and specialty pharmacy that are, stay within kind of very specific swim lanes. We do not have a single manufacturer that is not, begging us in one way or another to bring our program increasingly into specialty. So we definitely have a lot of avenues. For us, it's always a question of, discipline and thinking about what can we do well.
Well, I really appreciate your time today. This has really been informative, helpful. I imagine the audience were after this, they're like, wow, this is super cool. Great topic, very fascinating company, really trying to help create engagement, better, healthier, happier people. And your company's doing that with your peer support, good starters, and then, helping. I could only imagine when you multiply that, millions, hundreds and hundreds of thousands of people. As we wrap up, anything do you want to share, how they can find you, any other information before we kind of finish?
Sure, sure. Our website is always a good start. No pun intended. Always open to LinkedIn connections. Often an easy way, and simple email to Michael@Pielo.com. Always works. We're a very open and collaborative company. I think I said it early on. We believe in medication adherence. We believe patient engagement is complex. We believe there are no silver bullets, and we definitely stick to the belief that this is something that we need to collaborate on.
Cool. Well, thank you so much. It's been awesome having you, and I learned so much today. Really did.
Great. Yeah. Thank you so much. Thank you so much for having me. This is great and something we always enjoy talking about.
Cool. Have an awesome rest of the week.
Great. Thank you.